Hi, everyone, and welcome to episode 147 of the Veterinary Behaviour Chat podcast. So, as promised, this is episode 2 in our little duo of oral alpha-2 agonists. So, in episode 146 last week, I spoke about clonidine. And in this episode, I want to speak about guanfacine. And if you did listen to last week's episode, you'll remember I said that I wanted to kind of a little bit compare and contrast these two medications because they potentially might be used for quite sort of similar or in quite similar circumstances, perhaps for quite similar case presentations, but there are some differences, and there might be some times or some cases where the choice of guanfacine might be superior to that of clonidine, and we'll go through that. I have to say, I became quite familiar with guanfacine earlier this year when we had a shortage of clonidine in the UK. Now, I normally practice out of the UAE, but I do see quite a lot of cases in the UK on a kind of referral basis and a sort of vet-to-vet, guidance basis. And there was one particular case, if you're in the Behaviour Case Collective, or if you listen to my Canine Arthritis Management, the Chronic Pain Symposium masterclasses, you'll have heard me talk about a dog called George, and the caregiver is very happy for me to share his name, who was really quite an extreme case. He had a combination of abnormal repetitive behaviors, so quite significant compulsive behaviors, and also there was an element of hyperactivity, hyperkinesis, inability to settle, just, in general, hyper-vigilance, hyper-attentiveness, and those two things combined made this a really difficult case to manage. And there was the clonidine shortage in the UK, and I really wanted to add an alpha-2 agonist to his protocol. So I reached for guanfacine, and I have to say I hadn't used it a lot before. I had used it together with my supervisor in the US, but it wasn't really a medication that I was super familiar with. So I kind of chose it a little bit out of not desperation, but because we needed something for this poor guy. And it ended up being an absolutely brilliant addition to his protocol. And it was the thing that actually made the difference, I believe, between that dog remaining with that family or not. So I was then really interested to hear a presentation in this year's Veterinary Behaviour Symposium in Seattle about guanfacine and sort of a retrospective look at guanfacine used in 65 dogs in the period between 2022 and 2025 in this particular diplomat's practice, and to see some of the differences that they saw when they used guanfacine in kind of contrast to clonidine. So I thought I'd start off by giving us a little bit of sort of mechanisms of action. Now, last week I kind of went through the mechanisms of action of alpha-2 agonists in quite a lot of detail. And you might remember me talking about the 3 receptor subtypes of the alpha-2 receptors. So we've got alpha-2A, B, and C. And if you remember back, clonidine was a relatively non-selective medication that kind of binds to all 3 receptor subtypes. Guanfacine, on the other hand, is quite selective for the alpha-2A receptor subtype, which is really interesting because it's the B and C receptors that are mainly responsible for sedation and hypotension. So we therefore already get a bit of an inclination or a bit of a clue that guanfacine might not be quite as sedating as clonidine at effective doses. And that was something that was also seen when looked at kind of the retrospective sort of look at the cases that this particular practice in the US did. So that's kind of, I think, the first sort of particularity, I guess, about guanfacine. If you want to know more about the mechanisms of action of the alpha-2 agonist, then please do go back to last week's episode. I explained in quite a lot of detail how the alpha-2 agonists kind of have their effects. But so this is just one of the sort of, I guess, bigger differences of guanfacine compared to clonidine, is that guanfacine is selective for the alpha-2A receptor subtypes, and therefore we potentially get less sedative and hypotensive qualities when using it. Now, what we don't have is any kind of pharmacokinetic data in dogs for guanfacine. And again, last week, I shared that 2026 really new paper on pharmacokinetics and dynamics for clonidine in dogs. So we don't have anything like that for guanfacine. So we kind of extrapolate a little bit from the human literature where guanfacine is said to have a half-life of about 17 hours. So much, much longer. And again, if you think back to clonidine, just again, as a kind of compare and contrast, the half-life for clonidine in dogs was 0.65 hours compared to 17 hours for people for guanfacine. So again, we're not comparing like with like because we're comparing humans to dogs, but there is quite a difference in that elimination half-life. There are also a couple of papers on guanfacine in humans that kind of note exactly the less sedative and the less rebound hypertensive, perhaps effects or side effects in humans. So I think all of those things already kind of give us a little bit of an insight into how guanfacine might be different to clonidine. So I'm going to talk a little bit about what this particular practice that presented the guanfacine kind of study at the VBS, what they found. So their clinical observations were that definitely they saw a much longer duration of action than either clonidine or Cilios. So the other two kind of, I guess, by them commonly used alpha-2 agonists. And that allowed for an every 12-hour dosing of guanfacine, which can be so much more practical for many, many caregivers. And again, if you remember back to clonidine, we often need every 8 hours, every 6 hours. I've known my supervisor in the US also sometimes go to like every 4-hour dosing for clonidine where necessary, depending on how fast it's metabolized by an individual patient. But on the whole, with guanfacine, there was one dog in the 65 dogs that they looked at where they did have to go to every 8-hour dosing. But for the rest, it was every 12 hours. So that's already a massive bonus. They also observed clinically that guanfacine was less sedating. So that makes sense when we think about that kind of alpha-2A receptor selectivity. And they didn't see those rebound behaviors between the doses. So in clonidine, you very frequently, as the medication starts to wear off, you see a rebound, so a reoccurrence in either behavioral signs, but you can also get rebound hypertension. And that wasn't something that was noted with the guanfacine. So what might be uses for guanfacine then in terms of case presentations? Now, one interesting thing is, remember when I spoke about clonidine, I said that clonidine can be used both as an event medication as well as kind of a daily adjunct to a baseline medication. And quite frequently is, right? So I'll often include clonidine in a pre-visit pharmaceutical plan. I'll often maybe combine it with something like gabapentin and or trazodone because of the different neurotransmitter effects that it has. And I think that's not the same with guanfacine. I don't know whether it's because it couldn't be, but it traditionally just hasn't been used as an event or short-acting medication. It's traditionally really been used as an adjunct to a baseline medication. And that's exactly, I think, how it was used in this kind of retrospective study. So they looked at, as I mentioned, those 65 dogs from that period between 2022 and 2025. And they chose guanfacine as an adjunct in cases where the response to the baseline medication, and again, they used SSRIs, TCAs, and SNRIs most commonly, where the response to the baseline medication wasn't as good as they hoped it would be. So they chose an alpha-2 as an adjunct, and that's where guanfacine came in. Interestingly, in this particular retrospective study, guanfacine was also often chosen where clonidine hadn't been effective or where clonidine wasn't practical. So clonidine had potentially been the first choice of an alpha-2 add-on. And then for all the reasons that we mentioned, either too sedating, had to be dosed too frequently, or the rebound was too significant, they then decided to change to guanfacine. And when asked in the questions after the presentation, the presenter did say that initially that's how she used guanfacine, was where clonidine wasn't appropriate. But now, being sort of more cognizant of the potential benefits of guanfacine, she'll much more frequently reach for guanfacine as a first option when she's considering an alpha-2 as an add-on. So yeah, I think, whereas clonidine, we perhaps use much more frequently, for events, even if it's like walks, I guess, although the sedative properties aren't always great for walks, but maybe owner departures, vet visits, all those things, maybe even noise events where Cilio or one of the other licensed medications is difficult to administer, maybe for a dog that doesn't like the or a transmucosal gel being administered, then you might think about something like clonidine for a noise event. But for guanfacine, it's traditionally used much more as an adjunct to those patients where the baseline alone isn't enough, and we want to add in a daily alpha-2 to help with generalized symptoms. So in humans, guanfacine is FDA approved for hypertension, and the extended release formulation is also FDA approved for ADHD. And extralabally in humans, it's used quite commonly in children for things such as fear, anxiety, aggressive behaviors in children, traumatic stress symptoms in children. So a lot of sort of presentations that we would perhaps also commonly see in our canine patients. And so the kind of cases that guanfacine is often used in would be fear, anxiety, phobias, fear and anxiety related aggressive behaviors. And I personally have also used the alpha-2s and guanfacine in particular a lot for those cases where we have almost a little bit like these ADHD-like signs. And again, I just want to be really careful with the terminology here. We don't talk about ADHD in our canine patients, maybe yet in inverted commas, but where we have this kind of inability to focus, hyperactivity, hyperkinesis. So this was very much the presentation in the case of George, that dog that I kind of told you about. So, and again, always remembering that we want to pair our behavioral signs with their kind of purported neurotransmitter effect. So if we are thinking hyper-arousal, hyper-attentiveness, hyper-vigilance, all those things, hyperkinesis, hyperactivity, then we're thinking noradrenaline, right? And that's the neurotransmitter really that the alpha-2 agonists affect the most. Then if you think back to last week also, where I mentioned Dr. Jill Sackman has also performed a study where she uses SRIs in combination with clonidine for hyperarousal in dogs. And so, that could be definitely another indication for guanfacine, that kind of hyperarousal piece. So those would be the types of cases that I would think about. And for sure, this group that gave the presentation in Seattle, they talked about, where those cases were just didn't respond enough to a single baseline medication. All right. What about the doses? So the doses that they used was 0.02 to 0.2 milligrams per kilogram every 12 hours. And a mean effective dose of 0.1 mg per kg. So you could absolutely start at 0.02. I normally start at 0.05. That's where we started with George. And then I would work my way up to 0.1 mg per kg, but also knowing that we have a little bit more to go up if needed. So that would be the dose range that they used. And in their retrospective study, they found that 66% of dogs improved with the addition of guanfacine to their protocol. I think they had, was it maybe one dog or a couple of dogs that did better on clonidine, so they kind of reverted back to clonidine, but 66% of the dogs improved on the guanfacine. And I think, for sure, those reduced sedative and those longer dosing intervals would have made a big difference there. So what about adverse effects? What did they see? And importantly, the thing that they did not see was sedation, lethargy, somnolence, which is reported obviously for clonidine in dogs, but also reported for guanfacine in humans. So that wasn't seen with the guanfacine in the dogs. What they did see was agitation, increased anxiety, decreased appetite, some GI signs, and then for one dog they saw nighttime waking. But all of those adverse effects were reversible either by stopping the medication altogether or reducing the dose. So I think that's, again, an important thing to think about. So if we do get adverse effects, it might be worth reducing the dose initially before we completely decide that medication isn't useful. So yeah, I think that's kind of the main information that I have on guanfacine. I am going to say, just kind of personal clinical observation and experience, is I probably thought it took a little bit longer to see the beneficial effects from the guanfacine than immediate, if you like. So oftentimes with these short-acting medications, and such as clonidine, gabapentin, trazodone, we oftentimes expect the effects to be almost immediate. We all know that with our baseline meds, we have to wait 4 to 6 weeks, maybe even slightly longer, in order to see whether those medications are going to be effective. Whereas with the short-acting meds, we always tend to think, well, actually, we should see results or effects quite quickly. And that hasn't always been my experience. Even with some of the other medications, it sometimes has taken a week or two to see the beneficial effects. And that was something that I've noted. I certainly noted with George that it took a couple of weeks to sort of see the beneficial effects of that medication. Now, that could be because it was, quite a significant case, quite an extreme case from a behavioral sign point of view. We never know whether the caregivers give the medications regularly, right? Like, there are so many factors that affect that, and we don't have any studies looking into that. But just from a clinical experience point of view, I found, for us to definitely say, yay, right, this medication is really helping, it took a couple of weeks to fully see and appreciate that effect. So that was a little bit on guanfacine. I just think I have heard it definitely being used more frequently. I for sure think that the presentation in Seattle would have given a lot more people the confidence to start using guanfacine. Like I say, I used it eventually out of desperation because I really wanted an alpha-2 agonist, and we couldn't get clonidine, especially for the size of the dog that George is. So I went to guanfacine. I made sure that I checked and I asked, and I made sure that I had all my ducks in a row, and I read up in the literature, and I knew that it was safe, and I knew that also that actually there could be some benefits. So yeah, I would urge you to, if you're struggling with clonidine, if you're finding it's too much in terms of dosing frequency, or if you're seeing that kind of sedation that can come at the higher doses with clonidine, or if you're seeing those kind of rebound effects in between doses, but you still really feel like you want to use an alpha-2, I would urge you to give guanfacine a go and see how you feel about using it. So yeah, and I think we don't have any studies, but I think that this presentation in Seattle was a really great step forwards to kind of really encouraging the use of guanfacine and to sort of understanding its use. I know that a lot of my colleagues in the US do use guanfacine quite regularly. I guess, maybe in other parts of the world, we're even already not really that comfortable with clonidine yet. So then guanfacine is kind of another step. So I just wanted to give this little duo of episodes to give you confidence in using guanfacine. If you would like to learn more about psychopharmacology, then please join my Psychoactive course. I think you will really enjoy it. And we are definitely updating the course, or I'm updating the course as new information like this comes to light, and making sure that it becomes much more accessible. If you have any vets, GP vets, other professionals that are interested in guanfacine, please feel free to signpost them to this episode. And if you're curious about my Behaviour Case Collective, so that's where I presented the George case, let me tell you a little bit about that. So it's a monthly membership. You can pay either month by month, or you can pay for the whole year in one go, and you get 2 months for free. And every month I do a bit of a deep dive into a behavior case. So we jump on a live Zoom call together, but everything's recorded, so you can absolutely watch it back. And I present a case, and they can be anything from quite basic cases to really complex cases. So I want to make sure I kind of share the breadth of cases that we see. And then we have a conversation about it. So we discuss why I did what, what could have been other options, what other people's experiences have been. And it just ends up being a really brilliant conversation about managing certain types of cases. I also pull out a bunch of literature for you, sort of relating to each case, what we talk about, and all of those things are kept in a vault together with all of the recordings from the previous cases. And so if you join the membership at any time, you get access to all of the previous month's recordings. So you get a whole library of prior case discussions for you to peruse and look through. And I also quite frequently have guest speakers. So coming up this month, actually, in August, coming up this month in August, I actually have the wonderful Andrew Hale joining me. And it's going to be slightly different. So we're not going to present a case per se, but we're going to talk about all those things that are absolutely imperative to think about for every single case we see. So those would be things like creating really strong and positive relationships with the caregivers, taking care of ourselves, setting boundaries, how we can support caregivers in their emotional journey, as well as supporting the pet in their behavioral journey. So it's a little bit more about the human factors, I guess, of managing cases, which I know that a lot of the people that are already in my membership have expressed a strong interest in. And it's something that is relevant to every single case we see. So that's happening this month. I had the wonderful Dr. Amber Batson join me a couple of months ago, and we did a behavior and GI signs, so gastrointestinal health case together. And I will often have guest speakers join me to talk about cases that relate to their speciality. So it's a really cool membership to be in. So I'm going to put in the show notes. I don't have any papers for Guanfacine, so I can't put any papers for Guanfacine in the show notes, but I'm going to put in the show notes information about Psychoactive and information about the Behavior Case Collective. So if you're interested in learning more about those, just click the links and it will take you through to the pages that give you all the information you need to know. Okay, so I hope those 2 episodes have been beneficial. It's been a bit of a journey into oral alpha-2 agonists. So we talked about clonidine last week and Guanfacine this week. And yeah, I hope it's encouraged you to maybe try Guanfacine where you feel that you might want to use an alpha-2, but clonidine isn't maybe the most helpful. All right. I very much look forward to seeing you next week for episode 148. And yeah, I hope you've enjoyed this one, and bye for now.